Welcome to our detailed exploration of acute pancreatitis. I am Paromita Chatterjee, and today we'll uncover the critical aspects of the painful and potentially dangerous condition which is called pancreatitis. Today we'll discuss about the medical approach of pancreatitis. Before we start the discussions about medical approach, previously we covered the anatomy of the pancreas, definitions of the pancreas, etiology of pancreas, and pathophysiology of pancreas, signs and symptoms of pancreas, and also the complications of pancreas. Now the medical management of pancreas. The medical approach to acute pancreatitis often begins with hospitalization. Patient kept nothing per mouth, means no oral intake. For what reason? For to rest the pancreas, and IV fluid administered to ensure hydration, and pain management is primary approach of medical management. Patient comes with chief symptoms of acute pancreatitis is the abdominal pain. Chief complaint is the abdominal pain that is typically reported in the epigastric regions, right upper quadrant, which in the majority of the patients it radiates to the upper back or right shoulder. So it requires opioid analgesic, and morphine is the drug of choice of opioid analgesic. Next drug is dicyclomine. Dicyclomine is the antispasmodic drug. Antispasmodic means it decreases the spasm. So how it decreases the spasm? It's a anticholinergic drug. Dicyclomine is the anticholinergic drug used to relax our smooth muscles of the intestine. How to act? Its actions partially through the antimuscarinic activity of the M1, M3 and M2 receptors. It inhibits the actions of bradykinin and histamine. If bradykinin and histamine is inhibited, then result on the smooth muscles, indirect actions on the smooth muscles, and decrease the strength of contractions of the spasm. It's one actions. And another action is it decreases the volume and concentrations of bicarbonate and enzyme secretions. Our pancreas has two ductal system. One is ductal cell epithelium and another one is acinious cells. In the ductal cell epithelium, it releases the bicarbonate rich fluid. In pancreatitis, this bicarbonate rich fluid gets thickened and obstructs our outflow of pancreatic enzymes. In that case, dicyclomines helps to decrease the volume and concentrations of bicarbonate and enzyme secretions. Another one drug is carbonic anhydrase inhibitor. It also decreases the volume and bicarbonate concentrations of pancreatic secretion. Then antacid. How to act antacid? It neutralizes our gastric hydrochloric acid secretions and also decrease the production and secretions of pancreatic enzymes and bicarbonate. Proton pump inhibitor decrease the hydrochloric acid secretions because hydrochloric acid stimulates our pancreatic activity. If we decrease the hydrochloric acid secretion, then pancreatic activity will be decreased. If pancreas is in resting position, then pancreatic enzymes actions will be decreased. So that's how the proton pump inhibitor acts on the pancreatitis. And if gallstone is present in pancreatitis patient, then we do endoscopic retrograde cholangiopancreatography to remove the gallstone. And we do alcohol cessation. For alcohol cessation, counseling and support for abstinence. In case of hypertriglyceridemia, medications and dietary modifications should provide to lower the triglyceride level. If any infections is pancreatic necrosis or infections is present, then we may provide antibiotics. Generally not used unless there is evidence of infected pancreatic necrosis or other infections. So these are all medical support. Then next one is nutritional support. In nutritional support, first we give pancreatic enzyme replacement therapy, which is called PERT. Pancreatic enzyme replacement therapy to aid digestion and absorption of nutrients. In pancreatitis, digestion and absorptions will be hampered because in advance activations of pancreatic enzymes in the pancreas. In normal situation, pancreatic enzymes activated in the duodenum and helps to digest the half digest food which comes from the stomach. So in pancreatitis, the pancreatic enzymes are activated in the pancreas and helps to digest the pancreatic tissue. So what about the half digest, partially digest food which comes from the stomach to the duodenum? This is not digested properly in pancreatitis because pancreatic enzymes are absent. So we provide artificial pancreatic enzymes replacement therapy to aid in digestion and absorption of nutrients. And we provide low fat diet and frequent small meal. Initially in acute pancreatitis, patient kept NPO. For what reasons? Pancreas get rest to reduce the pancreatic secretion. If pancreas in resting condition, then pancreatic secretions will be decreased. And depending upon the severity of the pancreatitis, we provide enteral feeding. If any problem happened in enteral feeding or nasogastric tube feeding, then we transfer to the parenteral nutrition. When the patient cannot tolerate the enteral feeding, the first we kept the patient in nothing per mouth condition, then we start nasogastric tube feeding. If any infection present or if patient cannot tolerate the enteral feeding, then we go for parenteral nutrition. If IV lipids are ordered in acute pancreatitis patient, then we should check the triglyceride level. When the food is allowed, in case of patient is in small amount of food, then we may provide frequent feedings, small frequent diet in frequent interval, small and frequent feedings in frequent interval. And the diet should be high in carbohydrate because carbohydrate diet least stimulate the exocrine portion of the pancreas, because exocrine gland release our amylase, protease and lipase. So carbohydrate diet least stimulate our exocrine portion. If patients complains intolerance of oral food, if patient report pain or abdominal girth increase or elevations of serum amylase lipase level, then we may stop our oral feeding. We may provide supplemental fat soluble vitamins. These are all our nutritional management. Then comes to the most important portion, nursing management. What we should do in the nursing management? Nurses play a pivotal role in managing pancreatitis. Comprehensive assessment involves monitoring vital signs, pain levels, abdominal conditions or girth, observing for signs of complications, and tracking fluid intake and output are crucial and critical. Effective pain management includes administering prescribed analgesics and implementing non-pharmacological measures. Ensuring adequate hydration and electrolyte balance through IV fluids is essential. Nutritional support progresses from NPO status to the diet advancement, coordinate with dietitians, and also last of all important nursing uh, responsibility is patient educations on lifestyle modifications, recognizing complications, enzyme therapy is a vital, and providing psychosocial support and involving the family members in care can enhance the patient outcome. And also in the nursing management, we should do collaboration with a multidisciplinary team, ensuring the comprehensive care. So nursing management play a vital role in managing the pancreatitis. So we discuss about the different nursing diagnoses which we formulate in case of pancreatitis. First, acute pain related to edema and inflammation. Goal: reduce the pain. Which will be the nursing interventions? Monitor pain for severity, onset, duration, and precipitating factors. Administer analgesic as ordered. Advise the patient to sit in an upright or slightly forward leaning position. Provide calm and quiet environment. Discuss with patient his fears and anxieties regarding pain. Use pain relief techniques, biofeedback, diversional therapy, yoga, breathing exercise, etc. Next nursing diagnosis is imbalanced nutrition, less than body requirements related to vomiting, pain, nothing per oral, and gastric suction. Which will be our nursing goal? Maintain normal nutritional status. Then our nursing intervention will be assess the patient nutritional status by weighing the patient every other day. Monitor laboratory values or glucose level, electrolyte level, serum albumin and protein level. Auscultating for bowel sound. Administering nutritional supplements including pancreatic enzymes. Healthy teaching regarding stress reductions, avoid alcohol, and signs and symptoms of diabetes. Next nursing diagnosis will be fluid volume deficit related to nausea, vomiting, restricted oral intake, and fluid shift into the retroperitoneal space as evidenced by hypotension, tachycardia, restlessness, pallor. Goal: maintain normal fluid volume status, which will be our nursing interventions. Measure and record 4 hourly the following: what? Intake output chart, skin turgor, vital signs, electrolytes, burn, hematocrit, and daily weight. Administer fluid according to doctor's advice. Administer medications according to doctor's advice. Provide positive verbal support for consuming fluids. Provide change of position exercises every 4 hourly. Health teaching regarding recognition of signs and symptoms of dehydration and measurement of intake and output. Risks for ineffective breathing pattern related to abdominal pain and pressure. Goal will be maintain normal breathing pattern. Assess the patient's breathing patterns. Observe respirations for depth and regularity and rate. Observe respiratory effort. Observe for evidence of respiratory distress such as use of accessory muscles, use of intercostal muscles, rapid or difficulty breathing. Administer oxygen as ordered. Place the patient slightly forward leaning position. So, nursing management play a vital role in the management of pancreatitis. We discuss about the definitions of pancreatitis in overall in pancreatitis study, sign and symptoms, etiology, pathophysiology, complications, medical management, nutritional management, and a nursing management. In summary, understanding the complexities of pancreatitis, its complications, and effective management strategies is crucial for improving patient outcomes. Through a collaborative approach involving medical and nursing interventions, we can provide comprehensive care to those affected by this challenging condition, which is called pancreatitis. So, thank you.